Hello. Yes. Hello, Dr. Vinita and Dr. Asha. I am Dr. Amed Hadrak from MGMS Sevagram. Am I audible to you all?
Yes, sir. Good
Yeah.
afternoon.
Good afternoon. Good afternoon. Welcome to the workshop. Dr. Ruchita just joined with us.
Yeah.
Good afternoon. Ruchita, did I make you host here? You know, you had this control of recording and everything, or should I make you host?
Sir, I am co-host right now. Sir.
So should I make you host? It is better for you to operate this WebEx
Sir, it's
platform.
okay because sir, it's okay. Co-host and host have all equal rights.
Okay, then no issue.
No need to change our roles.
Okay. Hmm. Good afternoon, Dr. Himanshu. Hello, sir.
Ready? You can let me start. Thanks.
So your voice is very feeble.
Can you hear me now?
Yes, but still not so loud.
Okay.
Dr. Himanshu, sir, I guess we should wait for 5 more minutes to allow all the passengers to wait for the participant. We have 25 and the number is 14 here.
Sure, not a problem.
Okay, sir. Thank you.
Hello, Dr. Amay. Good afternoon.
Good afternoon, Arjun.
Amay, I was not able to hear the voice of Dr. Himanshu sir clearly.
Okay, okay. We will rectify this problem. So I guess the mic is far from some issue with your mic. So please, can you
Sure.
speak again so that
Is this clear to you?
yeah, I can hear you, but the voice is very low, sir. If
Okay,
you
let me look into
open
it.
my
Okay.
yeah.
All right, Amay, I've changed my mic. You're muted.
Yes, sir.
Unmuted.
Yeah, yes, sir. Now we can hear you very clearly.
Sure.
Dr. Arjun, the
Yes, it was
voice
well.
is clear to you? Yeah. Yeah, thank you for the rectifying the issue. Thank you, Arjun.
Amay, I'll need the presenter, right?
Yes, sir. Just remove. Yes, now you are the presenter. So
Thank you.
I guess we should start our workshop. Dr. Abhishek sir is also here, our organizing secretary. It's already 2:10, so we should begin. Dr. Himanshu sir, should we start? Dr.
Yeah,
Ruchita?
sure. I'm
Yeah.
comfortable.
Dr. Ruchita, you can go ahead. Ruchita, you are not audible.
Yes, sir. Am I audible, sir?
Yes, you are now.
Uh, we are very glad to have you, sir. Uh, we welcome the organizing team from MGMS, welcome all participants and Dr. Himanshu, sir, who is working as a professional additional professor at Indian Institute of Public Health, Delhi. And his areas of interest is human resources for public health and impact evaluation. And we are very glad to have you, sir, for this workshop. So, n- sir, we can start our presentation. The stage is yours, sir.
Ruchita,
Thank you very
excuse me
much.
for. Yes, sir. Thank you. Just let me give. I want to speak here. Good afternoon, all, and good afternoon, Dr. Himanshu Gandhi. I, Dr. Amay Dhatrak, along with our organizer secretary, Dr. Abhishek sir, and Dr. Ruchita from MGMS Sevagram, welcome all the participants in this workshop. Here at the IIPSM Youth Conquer 2021. It is with the special excitement that I am pleased to welcome Dr. Himanshu Gandhi to the workshop of a health impact evolution as a resource person. It is my privilege to introduce Dr. Himanshu. Dr. Himanshu is MD Community Medicine and also has done his Masters in Clinical Epidemiology. Sir has also done his fellowship from Wellcome Trust Research Foundation, and currently he is working as additional professor at the Institute of Public Health Delhi and has a strong background in a human resource for health and the impact evolution. So before starting the workshop, may I request all the participants to introduce themselves. Preferably, we should stream our video, and I will call one by name, and they can unmute themselves and they stream their video. So we have an introduction session. Dr. Abhishek sir, our organizer secretary, is here also. So I guess we should start with sir. Abhishek sir.
So at the outset, I'd like to thank Dr. Himanshu personally and IIPH for all their support. I mean, it was just a phone call, and I did not have to put any efforts. Everything was agreed upon so easily, and everything has happened so smoothly. So thank you for that, and we are really obliged for your support. And for Himanshu, I'll only say that probably he is one of the best persons who can help us learn about impact assessment. There are very few people who can speak from their own experience. And when your own work adds to whatever you are going to speak, it adds a different value to whatever these people deliberate. And I think Himanshu is one of them who does not only know the theory of impact evaluation, but then he has practiced it himself, and we are really privileged to have him with us today. So thank you, Himanshu. Thank you for agreeing, and we please accept our heartfelt gratitude for all your support for this particular conclave. Thank you.
Thank you much, Abhishek. Thank you.
Thank you, Abhishek sir. Dr. Arjun.
Hello, good afternoon, everyone. I'm Dr. Arjun. I'm working at MJMS Sevagram. I'm not currently in Sevagram, I'm in RSTC Anji, and I'm happy to join you all and looking forward to learn from the Dr. Himanshu sir. Thank you.
Thank you, Arjun. Welcome. Dr. Aarti.
Hello.
Yes, you are audible. Please
Good
go ahead.
afternoon, everyone.
Good afternoon.
Yeah, I'm Dr. Aarti. I'm from Index Medical College, Indore. I'm working as professor in community medicine.
Welcome, Dr. Aarti. Thank you. Dr. Anila Vargashi. Okay. Dr. Aparna Chaudhary. Please introduce yourself. Yes,
Good
you are
afternoon. Good afternoon, everyone. Yeah,
good afternoon.
I'm Dr. Aparna Chaudhary, and I'm currently working as a medical consultant for WHO National Tuberculosis Elimination Program based in Lucknow.
Yes, welcome. Dr. Debashish.
Good afternoon, everyone. Myself, Dr. Devashish Pandit. I'm working as a tutor at the Sri Chandra Medical College, Cuttack.
Okay. Dr. Priyasha Panda. Dr. Panda. Dr. Sadhna. Please unmute yourself and introduce yourself. Dr. Sadhna. We go to the next participant, Dr. Vinita Singh.
Good afternoon, everyone. Myself, Dr. Vinita Singh. I am currently working at GMC Chandrapur.
Okay, welcome. So that I see here the name Dr. Yukti Bhandari.
Yes, sir. Hi, I am Dr. Yukti. I'm a second year postgraduate researcher in medical Delhi.
Okay, welcome. Dr. Ronaki Maunika.
Good afternoon, sir.
Good
Hello.
afternoon. Hello. Yeah,
Sir,
you are audible.
myself, Monica, sir. I'm doing my second year post graduation at Government Medical College, Andhra Pradesh, sir. Thank
Welcome.
you.
Thank you for joining.
Thank you, sir.
Dr.
Thank you.
Dr. Gaurika Saxena.
Good afternoon, everybody. I'm Dr. Gaurika Saxena. I'm an implantologist. I'm currently pursuing MPH from AIMS Rishikesh.
From Rishikesh. Welcome. Dr. Mayawati. Dr. Mayawati. Dr. Suchitra Mankar.
Hello, good afternoon. I'm Dr. Suchitra Mankar.
Hello, ma'am.
I'm based in Pune. I'm the founder of a company called Doorstep Health Services Private Limited. I'm a veteran from the armed forces.
Welcome to the for sure. Thank you for joining. If I miss any name here because I called someone has joined late, so they can unmute themselves and they can introduce themselves. Meanwhile, I want to tell you that if you have any questions, you can raise your hands or put your question in the chat box, which we take later on with the permission of the resource person, Dr. Himanshu. So anyone who joined late, please, they can introduce themselves.
Hello.
If I miss someone. Hello,
Hello, I'm Dr. Mayawati from
Yes.
I'm working as associate professor at the SKN Medical College, Pune.
Okay. Welcome. Again.
Hello.
Hello.
Hello. Yeah, I
Yes,
am
Dr.
Dr.
Asha.
Asha.
Yes,
Dr.
ma'am.
Asha Solanki. I am a tutor and final year resident in GCS Medical College, Ahmedabad.
Okay. Welcome, ma'am.
Thank you, sir.
Hello.
Hello. Yes, please speak.
Myself, Dr. Sadhna. I am a third year resident from SMS Medical College, Jaipur.
Welcome, Dr. Sarna.
Hello, I'm Sarin Kumar. I'm finally a postgraduate student in MGMS Sevagram.
Welcome, Sarin. Okay, so I guess our introduction part is over. I request now our resource person, Dr. Himanshu, to please take over the session. Sir, over to
Thank
you.
you very much, Amay.
Thank you, sir.
Amay, can you please give me the presenter rights again?
Again, okay, sir.
Yeah, I don't have those. Okay. At the outset, a very good afternoon to everybody logged in for this on impact evaluation. Beyond the introductions, let me set across the stage by giving to you some background about what I'm going to cover and what can you expect by the end of the 3 hours. The session that I'm going to present to you is a lot of teaching that I do for an international audience every year. It's part of a 15 workshop that is a stream of universities and institutions which work in the area of monitoring and evaluation. I work as a resource faculty for that workshop, which is globally held either in Asia or in Africa. And the workshop is a fairly prestigious but a very expensive workshop with fees ranging about $5,000 for a 15-day workshop. So what I'm presenting to you is contents from that workshop as part of a very introductory session wherein I'm going to talk about an area which is very much neglected in most countries, which is the area of impact evaluation. Now, given that we have some constraints that we are not face to face, but technology is helping us connect virtually. Given that bandwidth sometimes can be an issue at the end of the presenter as well as at the end of the listeners, I see that the organizers have recorded the session, and I'm sure they will be able to share some bits of the versions for you in case you miss out on certain things while I'm speaking extempore. I have a longish presentation for all of you, and I'll be taking some examples to highlight issues, particularly around where the concept of impact evaluation differs from our routine understanding of evaluation. A lot of us who have been working within the healthcare sector have grappled with some questions around impact in different capacities. So let me start sharing my screen, and I will just start the presentation. And what I plan with all of you is about an hour-long presentation session, a 10-minute break, followed by the rest of the presentation. In case there is a concept that you think you are really not getting, do unmute yourself, even when the presentation is underway, and feel free to ask me questions. So let me once again thank the organizers at MGIMS Sevagram. I have visited the institution several times when Garg sir used to head the institution, followed by Mendele sir. And it's always nice to see a very, very young and eager set of faculty members always engaging and trying to give the best to IAPSF as well. So it's indeed a privilege to participate in this session organized by MGIMS. Without any further ado, let me jump across to the first slide. When we talk about program impact, let me highlight to you where we globally stand or what the problem statement actually is. We didn't talk about impact evaluation when I was doing my MD. So 15, 20 years ago, there was hardly a question of anybody talking about impact evaluation. We all talked about processes and outputs. But when some work was actually published in 2011, which was a very good piece of report, which was generated by Carlan, Dean, and Apple Jacob, which spelt out very clearly that just the developed countries, just the wealthiest countries, have spent a humongous amount of money, over $2.3 trillion, just on one particular aspect, poverty reduction. This does not even talk about healthcare investments at all. And if it is this quantum of investment that we are talking about, which is by far extremely, extremely large, just on one set of activities around poverty reduction, imagine the amount of money that has been spent by the wealthiest as well as by other nations on all the social and economic development programs. The struggle was that in spite of this money that was being spent, there was very little data that was available about whether these programs have actually worked. And this was classified very, very famously by this book as the evaluation gap. To summarize, we are putting in scarce resources, but we do not know whether those resources are actually making a difference that counts. Now, this was a situation, this was published in 2011. But what happened a little around that time period? What happened as a prelude to that work? The ILO, the International Labour Organization, reviewed a large number of studies, 127 to be precise. And as part of the report that was published in 2006, these 127 studies were covering more than 250 health schemes. So now we are talking about the health arena. So with more than 250 health schemes or projects that were running, a very small number that you could count on your fingers, only 2 out of those were able to accurately and give us a valid estimate of what is the program impact. And what is the impact because of the program, and the impact from other factors could be distinguished only by 2 studies. We all work in public health. We know that health improvements or improvements in outcomes don't happen just because of the health system. It also happens because of changes in the economic status. It happens because of changes in education. It happens because of overall changes in the health system as well. And you can't say that it's just my program or my initiative which has caused an improvement in the outcome. Precisely that same point was put across in 2006 by the ILO. Just like how we have the World Bank, the Asian Developmental Bank, we have the Inter-American Developmental Bank, known as IADB. So that works across both North and South America. Now, these are guys who are economists, and they reviewed 593 projects which were active, which was supported by the IADB in 2004. And less than a sixth of those, just about 97, had data on participants. But the number which had data on non-participants to actually give us a good impact evaluation, there were only 8 out of 593. So the magnitude of the problem globally was felt to be severe, because we're spending money, but the programs or the projects which are running do not even have the data to undertake the analysis on impact. Now let's clear up some terminology so that we are on the same page and we understand what is impact evaluation and what is not impact evaluation. Now in the first column, I have tried to talk about the kind of questions that we ask in public health. And in the column adjacent to it, I have put across the types of evaluation that help us answer some of these questions. So if there are questions about what are the health problems in a community, or what are the health conditions of the people, how are they currently healthy, unhealthy, this data could be part of needs assessment. Globally, it is also sometimes called as a diagnostic of health conditions. But practically, in our language, as we talk in India, it's needs assessment. When we talk about how good the program is, or what is the design of the program. So I was listening to somebody from Lucknow who's part of the RNTCP, now the NTEP. And every single time that we visit the Central TB division for meetings, we hear nice things about the design of the program. Now, if my question is to say whether the program's design is good or bad, whether it could be improved further, the type of evaluation falls under design evaluation, or program design evaluation is what it is referred to. The next aspect, which is very often undertaken, is about whether a given program with a certain set of guidelines, there is a bit of a background noise which I'm getting from probably a participant. Can I request the organizers to please mute all the other participants? Thank you. So when we talk about functioning of the program, functioning becomes part of process evaluation. So it tells us how well the program is actually running. Is it running as it was planned? The next question that comes across in our minds is, if the program is running well, are we getting the results that we expected? So that's part of either an outcome evaluation or evaluation of results. There is one more further step along the way, which is whether you're actually getting your long-term outcomes and whether the stated impact of the program is actually achieved, which becomes part of impact evaluation. And it's quite fashionable nowadays that if a program works, we also ask a question as to whether it is giving the results at a cost which is something that we can afford as part of an economic evaluation. So it could be different types of economic evaluation, either cost effectiveness evaluation or the other subtypes that we come across. These could either be complete or incomplete evaluations. So this workshop, the next 2.5 hours, are going to be talking only about one small type of evaluation, which is rarely undertaken, but is among the most terribly important ones for the setting that we are working in. And we're going to talk about impact evaluation. Let me tell you what is not impact evaluation. Since the EU support came to India in 2004 and we launched the NRHM in 2005, 2006, every health department and everybody who works in public health understands the terminology of the logical framework or the log frame. This is a management language. And the log frame classifies inputs, processes, outputs, outcomes, and final outcomes which in India, the final outcomes is what we call impact. Follow the same logic, it tells us that resources, money, material, manpower, methods, all those become part of inputs. The services, or the training, the logistics, all the IEC, all the implementation that you do is part of the process. It gives you certain outputs. So there are more patients attending, there are more beneficiaries that come along the way, which could lead to certain outcomes, which is usually behavior change. And it then leads to final outcomes, which we in the log frame in India call impact. And we say those are changes in mortality or incidence of the disease and so on. Here I've tried to fit in an example around contraception usage, where it is about improving contraception use or contraceptive usage in the community, which could be called as prevalence of contraception use, and how that is actually changing with the inputs and processes that the program is doing. And the impact, therefore, would be a reduction in the birth rate in a community. Very often, this is where people make a mistake, that impact in the log frame is not the same as impact evaluation. Impact evaluation is a different question which deals with causality. Impact evaluation doesn't say, has my mortality decreased or has the incidence of contraception use increased, that more and more people are using contraception. Impact evaluation actually says, did your particular intervention, project, or program change the contraception use? So rather than just tracking the changes over time, which actually is part of monitoring, it's never evaluation, impact evaluation asks us the question, is this change in my final outcome because of my project or my program? Okay, so that's the first bit I want you to remember, that when we talk about impact evaluation, we're talking about programs or projects. Programs are much more broader. They're more organized efforts towards social problems, whereas projects are more specific sets of activities with objectives to reach a certain program goal and help a program succeed. So project is a smaller part, a program is a much bigger thing. And programs can be in the health sector or even beyond, okay? This program can be delivered by NGOs, it could be delivered by a medical college, it could be delivered by a state health department, it could be delivered by the national government. So programs are bigger and broader, projects are smaller and more specific. And every single program that we read over time, that whenever we read in our textbooks or wherever we read the websites of those programs, we expect most programs explicitly to have stated what is the objective of a program, what are outcomes and targets, what is the target area where the program is going to run, which population is getting targeted, what is the intervention, who is eligible to get that intervention, and a conceptual framework which summarizes the program theory, and an implementation plan which includes the program start date, end date, how the program will be deployed and beneficiaries identified, services given, and so on. The first problem we face in impact evaluation and trying to say how good a program works, we will have to first and foremost know what the program is going to do. We expect that programs will have explicitly stated it, very transparently have stated it. Unfortunately, when you review most programs, not everything is written in black and white. So there is some implicit element which the program guys understand, we don't understand as well. So for any of you who has worked dedicatedly into a national program, their understanding of the people who work with the program is far better than a person who has attended a few sessions or is peripherally associated with the program. Because all those guidelines not necessarily are there in the public domain. They become part of an internal program documentation. So when I say I want to do an impact evaluation in the country, Never ever make the mistake of doing an impact evaluation without knowing your program well. You have to have a detailed understanding by diving deep into every single program component, first and foremost, to understand it, and then deciding to do an impact evaluation. So that's the first criteria before you start contemplating about doing an impact evaluation. On this slide is the key point that I'm summarizing in my first 5 slides. What is impact evaluation? For me, the definition of impact evaluation is very, very simple. आसान भाषा में अगर कहना हो तो how much of the change in your outcome is because of my program? How much of the change in the outcome is because of my program is a question of attribution, which we can also call as causality. And program impact evaluation says इतना ही मत बताइए कि कितना change हो रहा है या नहीं हो रहा है, ये भी बताइए कितना change आपके program की वजह से हो रहा है. So let's say we have a fantastic campaign, TB harega, desh jeetega, and you have lots of IC activities which are done there. The question I'm asking is that campaign responsible for the reduction in TB? Now, reduction in TB can happen because of several things that are done. It could be because of the PPP models that are working. It can be because of the JEET activities. It could be because of the NICSHARE platform. It could be because of a transition to an oral regimen with very good drugs that are available. It could be because of direct benefit transfer. But my question is different. My specific intervention that I'm asking because of an IEC campaign, kitna fayda program ko hua? That's the question that I talk about as an impact evaluation question. Remember, impact evaluation is not about saying हमने program launch किया और TB कम होता गया तो सब कुछ हमारी वजह से हुआ है. TB reduction could be because of the national program as well as because of changes in other socio-demographic and other age characteristics as well within a population. So you have to remove the effect of all those other factors to arrive at the answer of impact evaluation. Let me explain this concept through a simple set of pictures. I will continue with the same example of contraceptive usage. And I'm assuming that with a start in a program, the time which is being shown on the x-axis, and on the y-axis, we have the contraceptive usage. So the program starts, the contraceptive usage graph takes or changes its slope and goes upwards. The new program that I had around more training of health workers, better availability of condoms and copper teas, all that was made available as part of my intervention. And then when I reach maybe the program midpoint or the program end, I have another survey which is done. And that survey tells me that contraceptive usage has increased over time, and which is what is available here in the picture. The evaluation question, or the simplest evaluation question, is how much of this change from program start till the program end is due to the program itself. Let's call this as the evaluation question. And it's very simple mathematics, which even my daughter can do. Subtract the smaller number from the larger number, and it answers what is the change in the outcome. So if my contraceptive prevalence was 55% and now it is 65%, then it is 65 minus 55, 10 percentage points is because of my program. Very often, all countries like to do this very superficial and rudimentary analysis and say that the country launched a program, there is improvement in the outcome, and all of it is because of my country's efforts. Answer is incorrect. Because what really happens is that even without the program, because of the effect of other factors, you could still witness a change in contraception usage. So it could be because of better education, because of preferences about delaying the birth of the child after marriage, and several other social reasons could have also led to an improvement in the same period of time if the program was not offered at all. So now I have added a new fictitious line without the program. And I'm saying that even if the program was not offered, my outcome would have changed because of the effect of other factors. So the program impact is no longer the big change that you're seeing, which was available on the earlier slide. So all this change that you're seeing, which is put as the evaluation question, is not because of your program. It's in fact a much smaller component of that change in your outcome is particularly attributed or has causal linkages with your program. And program impact evaluation wants to find out what is the true program impact by removing the effect of the other factors. Now, this is where the question still is very, very simple. Again, if I ask my daughter to do that calculation and tell me what is the program impact, she can say that out of the 10 units of change, if I remove the effect without the program, so let's say that is 5 units of change, so that is 10 minus 5 is equal to 5 is the true program impact. It's as simple as that. Even a student who is in class 3 in India will be able to answer this question of program impact. It's very simple mathematics, nothing fancy there at all. But my problem is that when I say that there is a certain change in my outcome without the program, I do not know where this point actually is. I do not know, or I do not have the data. Without program situation doesn't exist. So if the question is, how much has RNTCP, NTEP reduced the TB in India? I can't say that I will take the data from start of RNTCP till the present time and say all the reduction that I'm seeing in TB is because of RNTCP, NTEP. I still have the effect of other factors. I still need to know what would have happened in India if the program was not running. Unfortunately, the data is not available. So that's where impact evaluation becomes very, very interesting and tricky. This is why doing impact evaluation is not everybody's cup of tea. You need to create a situation, a counterfactual status as it is called in econometrics, to identify what the status would have been in the absence of a program. So the first point that we talked about that I want you to remember is what is impact evaluation? Impact evaluation is nothing but how much of the change is attributed to the program. The equation for that is very, very simple. Program impact is the results with the program, and from that you subtract results that have been obtained if the program was never implemented. So if you remember the graph which is shown here, very simple. With program, say subtract TGA without program. So total may say subtract TGA without program, and you're left with what is your program impact. That's all that is being shown in a very simple equation form. Now, what is my problem in doing this work is the problem of the counterfactual, because my second term, that is what would the results be if the program was never implemented, is a situation which is not available to me. It is like an imaginary situation. Either you can have a program present or you can have a program that is not present. You cannot have a place where both program is present in the same village and absent in the same village. So this term, this hypothetical term in econometrics, very similar to control groups when we talk about, the concept is similar, but has some unique differences. The second term is called as the counterfactual. What does the counterfactual mean? So if you take it down to the individual level, it means that a particular beneficiary or a woman living in a village is either a program beneficiary or she is not. And here we are assuming that we have data on the woman if she receives the counseling from the health worker about contraception. And we want what the woman would have done if she had not received the counseling by the health worker, the same woman. Remember, the key word is the same or the identical woman. Now, that woman can only be in one of the two states. These are two independent states. So this is what we call as the counterfactual status. I therefore need special designs, not my conventional case control, cohort, or cross-sectional, but I need designs which are able to tell me how this woman would have behaved with a very valid estimate of the counterfactual status. So we get to some kind of a comparison group we will construct, but not like the ones that we conduct for our routine bread and butter research studies. And what that will do for me, it will tell me that where I'm putting the question mark, I need the identity of that point. I need to know what the change would have been without the program, what the change would have been in the counterfactual state, which is a hypothetical state without the program, and aggregate it at the population level. So this, in a very simple words, is what impact evaluation means and what impact evaluation actually wants to do. Now let us make some more complexities and add those into our simple graph that we had constructed. Now I'm getting into some mathematical terminology, but I will keep it absolutely simple so that all of you are able to follow it. Y is my outcome. I is the individual who participates in the program. So the outcome yi1 is the outcome in the individual I, and 1 because they participate in the program, what happens to them. yi0 is the outcome y in the individual I if the individual doesn't participate in the program. Okay, so the program status can be 1 or 0, so that's a dummy variable that you create, and you say yi1 or yi0. I1 if you're participating, I0 if you're not. So now it's the same picture, same graph. My outcome variable on the y-axis is yi. With the program, I have yi1, and without the program, I have yi0. Again, very simple. Program impact is nothing but a difference between yi1 and yi0. So those who participate with the program and those who do not without the program, subtract one from the other. Now, this is where it's not as simple a question when we say who is yi0 particularly, when we say who is without the program. Now think about it this way, that if I want to tell what the impact of the program is, I can have two types of people who become part of yi1. So let me go back to the figure and explain it here first. Let me say that all married women in the age group of 15 to 49 years are eligible to receive counseling from the health worker. So all these married women between age of 15 to 49 become part of my target group. Does that mean that all of these women will come and take the counseling session from the health worker? The answer is no. Some women will come and others will not. So I can define in a way, how do I want to calculate yi1 minus yi0? I can say, include everybody in the survey who is between the age of 15 to 49 and was eligible to receive counseling. And among those, you tell me how many actually took the counseling services. So I can compare people who took counseling services versus people who did not receive the program and get an answer. The second way of doing the calculation could be, don't just take people who took your counseling sessions. Take all the women, irrespective of whether they took counseling or not, as long as they are in the age group of 15 to 49, include their outcomes in the program group. Now, this is a fine distinction, but can completely change your impact estimate. What it means is that look at the line which is given here. The average impact of the program for the whole population of interest is what we call the average treatment effect. Remember, it's the whole population of interest, the whole population which was eligible to get your program. And we have another terminology that we can measure the impact on those who actually participated in the program. So it is called the average treatment on the treated, to distinguish from the average treatment effect. It means that if my medical college PSM department starts a program in one village and keeps another village as a control village, I have two villages, one village gets the intervention, other village becomes the control. Am I comparing the entire village which received the intervention with the entire village that got the control? Or am I comparing from the intervention village those who came to my clinic versus people who did not receive the intervention at all in the second village? So there's a difference between the two. And ATE will always be smaller or will show less benefit than the ATTE, because those who come to you and take the counseling will have better outcomes, hopefully, compared to the entire eligible population which comes or doesn't come to you, irrespective of their status, due to a survey. So ATTE, if you see in the formula which is given up here, is a conditional probability, conditional to those who participate in the program, whereas the ATE is among all the people who are eligible to get the program. It's very simple for you to remember if you remember the outreach sessions that you conduct as part of camps or as part of clinics in the rural areas. Those who come to your clinics and you just take those people and compare them with other villagers in the neighboring village, that's ATTE. ATE will be comparing your parent village where the intervention was running, irrespective of whether the woman came or did not come for counseling. Is this concept of ATE and ATTE clear to everyone? Can you please type in the chat box and confirm? Thank you, Aarti. Thanks for confirming. So I will keep on checking the chat box occasionally. Okay, Dr. Sadhna wants me to repeat it one more time. All right. So, Dr. Sadhna, the point that we need to understand is impact is a very simple language. Impact is just measuring with program and without the program. But with program means different types of individuals. Those who are in the geographic area and eligible to get the program, or when you say with the program, is it those who actually took the services of your program? So maybe all of us have heard about contraception, but not everybody went and visited the health worker. If I count in my with program group, the population that is counted in my survey is every single person's outcome as long as they are in 15 to 49, compared with the neighboring village? Or do I selectively only take a smaller group of people who visited my clinic or were counseled by the worker as the people who have received the program? So do you count the actual real beneficiaries who came in contact with the program, or do you count the potential eligible beneficiaries, those who are there in that particular village? So between these two comes to the definition of what is ATE and what is the ATTE. So now I am refining my question of impact evaluation to state it thus. Does my program have an impact on the health outcome? If yes, how much? Along with it, this was the main dish that you served for impact evaluation. There could be side dishes as well. So the side dishes could be, does the program have different impact on different groups? Does the program have different impacts on non-participants as well? Does it impact intermediate or just the final outcomes? Are there unexpected positive or negative impacts? Is my impact long-term and sustained, or is it short-term? How is this impact actually caused? What is the process behind it? What are the causal pathways? And is it cost-effective? So whenever globally we answer calls that are put across by global agencies where we are competing on multi-country grants, this is a slide that I would always like to remind myself when I'm making an impact evaluation proposal. I should definitely have the question on, is there an impact on an outcome? But along with it, I can have additional questions such as, does it have different impacts across groups? Does it affect my non-participants? Is it a transitory impact? Is it sustained over time? How does it cause an impact? And what is the cost effectiveness of it? So other things that are coming across could be plus minus, but the first basic question should always be present when you're trying to do an impact evaluation. Now, what we are going to talk about is, this will come in the second part of the presentation, not yet. I still have a lot more slides to cover, but we'll also refer to some kinds of procedures that help us guide how to select the right comparison group. So each evaluation design is a process by which we identify a very trustworthy and valid counterfactual status to answer the evaluation question. And depending on the design, there are different types of estimation processes, which I'll refer to in the second part of the presentation. So with this, it leads me to the point where we ask ourselves the question that if I have to get to the ATE or ATTE, whatever I'm wishing to calculate for getting to the impact evaluation, how do I get my comparison? How do I get my counterfactual state? Where is the data available from? What are the threats to a counterfactual that make it very poor? We want good counterfactuals. What are the threats to getting a good counterfactual? Evaluation designs have to keep 6 important points in mind in their search for a good counterfactual. What we're doing is we're just trying to answer the question of internal validity of the impact evaluation. We're trying to see whether the answer that we are going to get for a study has an appropriate, true, and correct answer. And to get to that internally valid answer, we need a good comparison. We need a good counterfactual. I have slides now on each of these 6 aspects that I want you to very carefully understand. The first point is about the presence of additional complexities within healthcare that influence the behavior of individuals and thereby modify the health outcomes. In order to understand this better, let us take the help of a conceptual framework. Now, for the same example of contraception usage, I have tried to draw a simple conceptual framework here. The conceptual framework at the left-hand side has 2 separate groups that I've simplified. The groups are factors that work at the individual or at the household level, and factors that operate at the community or the health system level. All right, so something closer to home and closer to home, and something which is more community based. So if I have data, I would want to see age, education, socioeconomic status, risk aversion, biology. Doesn't apply here, but how fertile you are, maybe that also makes a change there. Health service or to do with supply of goods or with the community level factors could include health facilities, presence and absence of staff, your program that you've introduced in the village as part of the medical college work, sanitation, schools. There could be several things. Okay, I'm adding some which just make some sense to me. Maybe you could exclude sanitation, maybe you exclude schools, but there could be other. Just an example. But rather than just saying about health facilities, maybe you are smarter and you talk about access to healthcare, price of health services, the quality of the service provided, the number of field workers, the quality of their training of the health workers. Several things can go into a conceptual model. And eventually in the healthcare sector, with all these changes that happen or all these factors that act, there is a push towards a healthy behavior and ultimately leads to healthier outcomes. So you could keep on adding programs. So maybe this applies for malaria as well. Maybe this applies for dengue fever. Maybe this applies even to COVID. But you could replace some individual factors and community factors to make it more COVID or malaria specific. But my problem is always going to be the absence of certain types of data. So maybe as part of my community health service provision program, I do have data on age, education, and wealth, but have no data on how risk averse they are to having a child. What is their biological endowment? Maybe I know how many health facilities are there, but I don't know the price of accessing those facilities. I do not have data on the quality of the services. I don't know about the quality of the counseling that you provide. I just know the number of the workers. I have data on the program, but maybe not on some other things and so on. So some of these variables that are important to us are observed. There is another set of variables which is important in the conceptual framework, but are unobserved. Incomplete information is going to cause serious problems in impact evaluation. Let's see some examples, okay? We will come to some of these examples a little later in the slide. I will give you from real life as well. The second bit which comes in is a very unique issue which we don't talk about at all within the healthcare sector, which is about selection into the program and how it operates fundamentally in the community and how it alters the way impact evaluation results are obtained. We always know that people self-select themselves to come to a program or to visit your facility. Individuals make those decisions. And they make those decisions based upon certain factors that make them different from the other people in their village. So not everybody who is an IAPSM youth member and was eligible to participate in this conference or in this conclave participated. There was some selection issue. Not everybody who participated in the conclave decided to participate in impact evaluation. There was again a selection process at play. Similarly, not everybody who has a cough will come to the health department. Not everybody who has a cough will come for TB testing. The ones who come to you are different from the people who don't come to you. The people who come for counseling for contraceptive usage are different from the people who don't come to you. So that is called selection issues into a program. That's one type of selection. The individual selects and says, I participate, I choose to come, I choose to wear a mask, I choose to get vaccinated. Selection issues operating at individual level. Sometimes selection issues are introduced by program managers. So when I launch a new intervention from my medical college for usage of contraception, I don't offer it in all villages. I offer it in a few select villages. I decide as the HOD of a particular medical college department where this program will run. So program managers target the programs to certain villages, communities, groups, which is also a selection issue. So PMJAY is not targeted for the insurance part of it to all of us. It targets, for equity reasons, a certain section of the population. That's targeting to a particular group. So that's also called selection. And these are called selection processes. There are two major types of selection processes. The first is self-selection of individuals. And the second is selection done by program managers. But if you forget all this story left, right, or center, what matters or what the consequence is that the program participants, those who participate in your program, those who come to you for counseling, are very different from the people who don't visit your health center for the counseling. The point I'm trying to make is that because of selection issues, these are not in your hands. These are, you started a clinic and said anybody can come, but still only a few select type of people will come to your clinic invariably. That's a selection issue. And this is always going to be there. And it makes your participants very different from non-participants. The implication is that if I compare apples and oranges, that's not a fair comparison to make. So I never, for impact evaluation, should I compare participants into a program with non-participants into a program. I should not compare village with the intervention versus village without the intervention, because if I do that, there is a selection issue at play. Your medical college decided to work in that village, maybe because that village has a larger burden of the larger burden of the disease. It has a health center jahan aapke doctor baith sakte hain. Maybe the panchayat members there are more supportive, or maybe there's a self-help group that is working, so on and so forth, which is going to make the two villages really, really different from each other. Therefore, impact evaluation will become more difficult if there are selection issues at play. The same conceptual framework which I had drawn up earlier, which I said this is my generic conceptual framework which everybody in PSM and community medicine understands. This conceptual framework gets modified when I talk about selection issues. Look at what is happening here. There is program participation being driven at the individual level. So not everybody in the village is coming to me. There is something in their age, in the education, in the health status, or in the economic status of some people in the village which decides program participation. So the conceptual framework is now slightly more complex, that you have an incoming arrow into program participation and an outgoing arrow from the program participation to the outcome as well. So even there, the same difficulties will be there, that you will not have data on certain outcomes. And the more the unobserved factors, the more the problems that you will have in impact evaluation. This will make it much more clearer. There are two persons, person 1 and person 2. We have data from these persons on the characteristics which are shown in yellow. So we have data on age, they have the same age, they have the same education, they have the same socioeconomic status and place of residence. But look at what has happened to the observed characteristic. 1 participated in the program and 2 did not participate in the program. And the outcome that you see in your data set by doing the survey is that 1 actually had a bad outcome and 2 had a good outcome. Just by looking at this data, what is the conclusion? The conclusion is that program में participate करोगे तो आपकी health status खराब हो जाती है. But is this a fair conclusion to draw? The interpretation of the impact at the individual level is wrong, because the individual 1 was maybe a very frail individual who could have an adverse health outcome, whereas person 2 was a very healthy, exercising, good diet, and all those things were there, and therefore has a better outcome. It's not because of their program status. It's actually because of an unobserved characteristic that you are actually seeing that change. So the point that we have made very clearly here is that the moment you have unobserved factors, even into seemingly very equal people, impact evaluation goes for a toss. Because they seem equal on observed characteristics, but your unobserved characteristics could bring in a difference, and therefore your impact evaluation collapses. Your medical college could have set up the program in a certain village because there is more need there. There are more poor people. There is less usage of contraception, and therefore you set up program there. So maybe the change that you see is a small change there, and the richer village next doors has a much bigger change because their education level is so much better. So do you say your program is a failure? That's actually not a fair comparison to compare these two sets of villages. So the message here on this slide is that when we talk about conceptual frameworks, these conceptual frameworks start getting more complex when you have selection issues at play within any situation. Now look at another type of selection process. This selection process is operating at the community level. Here, maybe it is because of the presence of a certain community leader who is very, very supportive of such an initiative, who encourages the medical college and requests them, please yahan hamare aake hamare health workers ko aap train kare. Or maybe there's a strong NGO that works there. And therefore your medical college starts working in that village. Now this is an example of a program placement driven by issues which are working at the level of the communities. And even there, a similar type of an effect could work. Maybe the outcome, now here you could take the example of malaria, that maybe you're getting more malaria there, or maybe you're getting more diarrhea there. Let's take diarrhea, you're talking about sanitation. So there is more diarrhea in spite of a health awareness campaign in that village, simply because the sanitation in that particular village was poor. Always remember, impact evaluation is an enemy of unobserved factors. Unobserved factors रहेंगे, impact evaluation का आंसर गलत हो जाएगा. So the first question that we had talked about, let me go back a few slides. We talked about multiple factors. We said that multiple factors influence outcomes. We need to know all of those, and we need data on all of those. That's point number one. We need data on everything, but there is also complexities added by selection issues which can work at individual or community level. You modify your conceptual framework, but even there, unobserved factors can cause problems. Let me now come to an even more trickier concept of spillovers followed by contamination. Now, all these terms that I'm using are relatively new for all of you who are attending this workshop. And there's a reason why these terms are new. Our conventional textbooks and our programs do not talk the language of impact evaluation. Unless we understand this language of impact evaluation, we will never be able to successfully conduct an impact evaluation. Let us now talk about something else called as a spillover effect. What happens to any intervention that is offered in a certain village? Let's say I again go back to the village where the counseling session is happening between a health worker and a lady. The lady is convinced about the benefits of contraception, and she goes back home, and the couple adopts the appropriate method as best suitable for them. But this lady will definitely talk to somebody around her. She might talk to her friends. She might talk to her sister, older or younger. She might talk to her mother-in-law. She might talk to her mother, and she will maybe spread the word around. And she will say that so and so options are available. And गांव में जो health worker हैं, दीदी हैं, उनके पास जाकर आप ये benefits ले सकते हैं. Now, this for the program is a fantastic thing to happen. It means एक को आपने काउंसिल किया तो उसका स्पिलोवर इफेक्ट से बहुत लोगों को फायदा हुआ. Information, education that is provided percolates to the rest of the community. You give a vaccine to a certain group of people, there is a sense that protection extends even beyond the people who are vaccinated, the concept of herd immunity. You give a cash transfer program to the people for doing a certain health specific behavior, a conditional cash transfer. They take the money, they spend the money in the same village. There is an improvement in the overall economy of the village. That is again a spillover effect. But now what is happening here is that the benefits of the program is not just on one lady. The benefits are to far more number of people than what you are actually counting among the people who visited your healthcare facility.
So simple mathematical calculation among the people who have attended your clinic or are in the age group of 15 to 49 for contraceptive usage is underestimating your program impact, because maybe that married lady is counseling an adolescent within the household who is just about 14 or 15 years old about contraception, and therefore the impact of the program is going to be much larger, because within a couple of years or 3 years or 4 years or 5 years, 6 years, when she gets married, she is going to start using contraception as well. So the impact of the program will be underestimated if there is a spillover effect. And if spillovers are there and you expect that there are spillovers, you should make efforts to count all those spillovers into your beneficiaries so that you're able to maximize and show my program has an impact. Very simple concept, but which means the impact evaluator has to know whether or not a spillover effect has occurred. And if it has occurred, how many people have benefited from the spillover effect? You should have a quantification of that. Not just how many people have benefited, how much is the benefit in the people who have got the spillover effect as well should be. Let me show this with a picture. Let me say that I start my counseling within a village in Wardha district. Now that's part of my treatment group, and far off within some other remote corner of Wardha district, let us say I have a comparison group. I'm not saying how we created the comparison. Just trust me that we have a good comparison group somewhere else. I have two groups, treatment, comparison. And my program impact is simple. Treatment group में फायदा कितना हुआ, comparison group में कितना फायदा हुआ, subtract करके बता दो. That's my program impact. But what happens because of spillovers? Because of spillover, your health worker gives counseling within a village, but even people in the neighboring village might visit your center and get some benefit. Maybe the ladies in the village are talking to the ladies in the surrounding areas as well when they meet over a market or where they actually interact with each other, or maybe when they go shopping, whatever be the reason. But there is a group with spillover effect as well. Let me see what happens to this spillover group once, or what happens to the impact calculation. Now, ideally, this situation is tolerable because I will have an impact estimate for my treatment group. I will have an impact estimate of comparing my spillovers with the comparison group as well. But sometimes my comparison village could be within my spillover zone. So I wanted my comparison village to have no intervention. But even then, somehow they heard about contraception, they heard about that there is some extra sessions that is happening in the neighboring village, that so and so methods are safe and should be easily practiced. And therefore, some people in the comparison group also start receiving the benefits of the intervention. Let's try to calculate it mathematically, and I will prove a point. Let us say that my birth rate reduces by 10 percentage points in the treatment area. In the spillover area, my birth rate on contraception use reduces by 6 percentage points, and comparison area, there's no change. Okay. So what is the impact of my new program on birth rate? So it is minus 10 minus 0, which is a benefit of 10 points of reduction. That's the impact of my intervention running in the village. Very simple, very easy to do. Now, what happens here in this situation is if I want to do this calculation, I know that 1/3 of my comparison group has received additional benefits of the counseling when it was not intended for them. They were supposed to be comparison group. So when I do that calculation of the impact of the program, I say benefit in the treatment group is minus 10. In the comparison group without the spillover, there is a benefit of 0, which is 2/3. So the comparison group got 2/3 of it does not get any benefit, but 1/3 of it gets a benefit of 6 points reduction. So my overall impact now is treatment minus the comparison. So it's treatment minus 10 minus 0 by 2/3 minus 6 into 1/3 Solve it, works out to a simple -2. So that net answer becomes -8. So although my true impact was a -10 impact, if there is a spillover effect, the impact of my program is actually reducing. That's obvious, isn't it? That if your comparison group stays like a pure comparison group, you get the correct assessment of your counseling. But if your comparison group, which was not supposed to get counseling, also starts receiving some kind of counseling because of a spillover effect, and you start comparing your treatment and comparison groups, you will get a biased, incorrect, wrong answer of impact evaluation. So spillovers, very crucial in assessment of program impact. Now, is this point of spillover effect clear to all of you? Yes, I will share the presentation after the session with everybody. So I'm seeing some questions that are coming to me privately as well as on the group chat, and we will definitely share it with you. At this point of time, please pay attention to what I'm showing on the slides. Are you with me at this stage? Are you all able to follow what I've covered till now? Thank you for confirming. Okay, so I'll move ahead with the presentation. Sometimes, very rarely, we get to such funny situations that the comparison group is wholly within the overlap area. And therefore, look at the final answer that you get. It's going to be a big underestimation of program impact. So spillovers are a program manager's friend. Okay, the program manager is happy. मैंने 5 लोगों को बताया, 5 से मैसेज 15 तक पहुंच गया. बट इम्पैक्ट इवैल्यूएशन के लिए ये सब बहुत ही अलग किस्म की प्रॉब्लम्स क्रिएट करता है कि आप करेक्टली अगर आपको बताना है कि कितना फायदा हुआ है, it becomes more problematic. So now my question to you is, what is the solution? Let's say this is the most terrible situation for an impact evaluator. How should I solve this situation? Any guesses? Okay, anybody has an option? They want to unmute and try to explain how can you overcome this situation of spillovers? Oh, you can ask for the source of information, but impact evaluation करोगे कैसे? पता तो चल गया कि वहीं से information मिली है, but उन्होंने अपना behavior भी change कर लिया है, तो impact तो आपको final में -10, -6, -4 ही मिलेगा. That's not the true impact. So the real way to actually get to it is minimize the spillovers by keeping the control group as far possible. If you see on the slide here, as far possible from the zone of spillover, from the possible zone of spillover effects. Your control group should be very far from the treatment group so that no spillover occurs. But is this a good solution? If I'm doing my intervention in district Gandhinagar, and if I select my control group from Himmatnagar, I will have no spillovers. But the problem for me is now Gandhinagar is so different from Himmatnagar district that this comparison becomes meaningless. So your control group is no longer a good control group. So here you have to work out a balance. You need a comparison group which is a good comparison, which is similar comparison, similar characteristics. But it not should be so close that there is actually within the spillover zone. So it should be pass पर बहुत पास भी नहीं, दूर पर बहुत ज्यादा दूर भी नहीं. So this is a game of mix and match that you have to try to work out, which you only learn by experience. Because if you don't solve this problem of spillovers, you will always have an underestimation of the program impact, which is something which is not desirable. Now with this, let me come to the next aspect, which is about condition. So now we heard about what is spillover, that your program's benefit is spreading to more people beyond your conventional treatment area. But there could be situations where there is another parallel intervention which is started by somebody else, which also addresses the same disease condition. So in the example of contraception, we have the Mahatma Gandhi Institute of Medical Sciences in Sevagram, and we also have the Datta Mege Institute of Medical Sciences in neighboring Savangi. Now, what might happen is MGIMS might have a program started in a certain village, in a certain taluk, and there could be a certain control area set up by them. But now you could have the neighboring institution running its own parallel program, or you could have the district health officer starting a new program by training their health workers on counseling for contraception, and maybe it all changes. So no longer is your village sacrosanct as a treatment or as an intervention area with there being a clearly defined control area. This kind of external factors which affect your intervention or comparison group are called contaminants. The word contaminant sounds bad, okay? Contamination, we always take it in a negative way. But contaminant doesn't just mean addition of bad things. It could be just an addition of something similar to your program, something else that the health department does. But from the perspective of your impact evaluation, your question and your project and program, it's a contaminant. If you're talking about whether there is changes in socioeconomic status, then maybe a contaminant could be the amount of rainfall in your district and the neighboring district. And if this contamination is differential contamination, which means it acts different levels of intensity in your treatment and in your control groups, then you have a serious bias that comes into your impact evaluation. If the contamination is non-differential, मतलब दोनों जगह पे similar चीजें हो रही हैं, दोनों जगह पे डिस्ट्रिक्ट हेल्थ ऑफिसर ने दोनों तालुक में अलग अलग किस्म की ट्रेनिंग नहीं, सेम अमाउंट ऑफ ट्रेनिंग करा दी, then you can say भाई everything else is same, nothing much has changed. But if something changes selectively in your intervention area and it doesn't change in your control area, or vice versa, it changes in control area but doesn't change in selection area, you have the problem of contamination. Your job always is that you should avoid it when you're doing an intervention to the extent possible. And even if your intervention is over 3 or 5 years period and contamination is inevitable, monitor the groups for any external factors or any changes that are happening over time. Vitally important. Otherwise, contamination will bias your results of the impact evaluation. So what we've seen till now is very easily we have tried to cover 4 factors. Multiple issues that affect the choice of a counterfactual. We say the solution is create a conceptual framework, list all those in a conceptual framework and collect data for them. The second issue in a good counterfactual is selection biases or selection issues that operate at individual and at the program level. We'll find out a solution for that as well. We model that into your conceptual framework and we do slightly different analysis, which I show to you later in the presentation. If there are spillovers, keep your treatment and control group far away from each other as possible to avoid spillovers. Contamination, monitor for contaminations. Let us now come to the simpler ones that are heterogeneous impacts and timing of effects. So let me now come across in the presentation to an issue on heterogeneous impact. Very often, I'll tell you, when we have evaluated the programs for impact, we have to be very, very careful about this issue of heterogeneous impact. Heterogeneous impact is inevitable for an intervention. Different population groups, different groups of vulnerability will have different responses to your treatment or different responses to your intervention. 100 rupees given to you and me extra in one day doesn't make too much of change in our life. But 100 rupees given to the mother of a poor child or to a very poor household is the difference between them being hungry and them being well fed for that day. वो 100 रुपए की कीमत वो हम उनके लिए हमसे ज्यादा है. Similarly, when I run a new intervention on counseling, on usage of contraception, maybe the college educated woman doesn't benefit as much from it, but possibly just a high school educated woman who comes for the counseling session gains much more from that same counseling session. Just a hypothetical example, but something that you can relate to or understand. So by education levels, it makes a difference as to who gets what from your program. Wahi worker, wahi health message, different impact. Socio-economic status पे कभी-कभी different impact मिलता है, poor and non-poor में. Rural urban में मिलता है. Quality services where the program operates से फर्क पड़ता है, कितनी quality की services हैं. And जब हम average program impact को calculate करेंगे, whenever I do an impact evaluation, I am summing up how the program worked at a country level and at a state level. Maybe at the country level it has worked decently well, but maybe my program made the most difference to the life of the poorest of the poor within the country. And that to me is a vitally important phenomenon to remember. So the average program impact hides the effects within subgroups. The extreme poor might see a much bigger benefit in mortality than the non-extreme poor, than the non-poor. And if I calculate the average program impact based upon what is the population proportion within each of these subgroups, if I do that average calculation, my average program at the country level could be a benefit of only 3 percentage points in mortality. But look at the benefit in the extreme poor. Maybe the benefit there is so large that maybe I don't run the program across the country, but I better target the program from everybody to just the poor or the extreme poor. Now, as a policy program person, this is very important bit of information for us. It means maybe -3 is not meeting your expectations and your decision could be stop the program, not worth the amount of money that we are investing in the program. But if I had done an adequate analysis with sufficient data, with power to calculate the difference or impact of the program in each subgroup, a result like this will convince the policymaker to, rather than stopping the program, target it to a certain section of the population. This is important from the program and policy perspective, and therefore impact evaluation should always remember that heterogeneous impact को आपको include करना है या नहीं करना है. The last bit that I'm introducing around the internal validity concept for impact evaluation comparison group is the issue of timing. Whatever design you take should give sufficient time for the intervention to mature. काउंसलिंग शुरू की पिछले महीने और इस महीने कॉन्ट्रासेप्टिव यूसेज चेंज हो जाएगा, बेवकूफी वाला एग्जम्पशन है. So don't take a calculation of contraceptive usage within a week or within 3 weeks or 4 weeks of starting your intervention in a village. Maybe do it after 6 months or a year. That is when you will actually see the impact. Decide the time point for the impact evaluation, whether you want to do a midline impact evaluation or an endline impact evaluation. Those clarities should be there with the program team when they are running the intervention. Now, I've come to about 1/3 of the presentation. At this stage, when I've covered 1/3 of the content, the key messages that I've given you are: what is impact evaluation? Impact evaluation is about saying, how good is my program? Or does my program make a difference? If yes, how much? The second point, I need a counterfactual. I need a comparison. But to get to a good comparison, I need good designs. And that good designs or internally valid designs should take care of multiple factors, selection biases, spillovers, contamination, heterogeneous impact, and timing of impacts. ये दो चीजें करना जरूरी है. And I'm not giving you any slides on external validity or generalizability. It's a concept which is much more simpler. And in addition to these two issues of internal and external validity, there are other design issues that we have conventionally learned in a medical college, which you also will be remembering, which you should not forget. These are additional bits that have added to your understanding of internal validity when I'm talking on the language of impact evaluation. Now let us take a quick 5-minute break and then reconvene again for me to start part 2 of the 3 parts of the presentation that I have with all of you. So I'll stop my screen share just for 5 minutes. I will be here. If you have to type in something in the chat box, feel free to do so, and then we reconvene. Can I request Dr. Amay to just pause the recording for the 5 minutes till the time
Yes,
we
sir.
are pausing the session?
Yes.
Thank you.
Sure. Sure.
Always to have an impact evaluation which gives you the average treatment effect, not just at the overall population level, but also at the level of individual subs which are important. So it's a matter of calculating the samples for the impact evaluation. Of course, the more you want to get into subgroups, the higher or the larger is the sample size which is required. So if resources permit, and if you can do an impact evaluation, do it by considering adequate sample size or calculating individuals within each subgroup of the population as important for you from it. Okay, so since there are questions that are coming, let me now take you through a few slides which tell you about which are the mistakes that you should avoid. There are two designs which are terrible. The first terrible design is a before and after, very much like a pre-post comparison. You have a survey data before your medical college started. This is starts the services, and 2 years after that again you have data, and you say jo 2 saal mein farak hua hai is all because of my program. In pictorial terms, what you're doing is you have baseline data before program and you have end line data after program, and you are saying the change that you witnessed between the two surveys, that is what is shown in yellow, is the program impact. Remember, our logic says that all of it is because of the program. There is some effect of other factors, and the rest of it, a very small component, could be program impact. But the before-after experiment has made, I wouldn't say experiment, the before-after surveys have made the assumption that the effect of all other factors is equal to 0. Nothing else has caused an impact on the program other than your intervention. Before-after studies are frequently encountered in literature, even at the national level, to say how the program made a difference. But for us, those who are trained even in the very basics of impact evaluation, it should be clear to every one of us that a before-after study makes a ridiculous assumption for impact evaluation, okay? For this particular purpose of impact evaluation, that the effect of all other factors is 0, and all the change is only because of my program. Therefore, we don't do before-after study for impact evaluation. The second thing, which should be obvious to you by now, that a comparison of enrolled versus not enrolled. Now, who are the people who are enrolled in a program? Take those. And the people who don't enroll into your program, who don't come to your clinic, who don't come to the counseling session within the same village or elsewhere, take them as controls. Doing that comparison opens your study to serious selection biases. Enrolled and not enrolled are apples and oranges. You will get neither apple juice, neither orange juice. If you mix them together, you will get a mocktail. Therefore, because these groups are different, even in the absence of a program, do not compare them for impact evaluation. सिर्फ ये 2 स्लाइड्स में ही आधे से ज्यादा इम्पैक्ट इवैल्यूएशन स्टडी समा जाती हैं, जो हम पढ़े बिना उसको साइड में रख देते हैं, तो हम डिजाइन का नाम देखते हैं, because these are not good enough to give you valid estimates of impact. अगर valid estimate impact का नहीं है, इंटरनल वैलिडिटी नहीं है, तो उसका कोई फायदा पॉलिसी लेवल पे नहीं होगा. सो बिफोर आफ्टर एंड एनरोल्ड वर्सेस नॉट एनरोल्ड का कंपैरिजन इम्पैक्ट वैल्यूएशन में अवॉइड किया जाता है. ठीक है. So what are the designs that you now use for impact evaluation? Well, the designs fall into two groups: experimental or non-experimental. And here towards the end of the presentation, I will introduce to you a slightly modified understanding of what do we mean by experimental. And what I'm going to talk to you about is not the language of Park, is not going to be the language of Leon Goddess, but I'm talking the language of econometrics, economics, okay, the science of economics. Very much related. Their statistics is far more advanced than what we do in our routine functioning. And this is where impact evaluation started from concepts. So some of the terminology that we use has its basis in econometrics. Now, what is an experimental design? So for the purpose of impact evaluation, remember, only and only a randomized controlled trial, only randomized controlled trial, not anything else, is an experimental design. Quasi experimental और वो सब जो हैं या नॉन कंपैरिजन वाले, उनको हम जो बायोमेडिकल साइड से कंपेयर करते हैं वो अभी के लिए भूल जाएं. Experimental is only RCT. So the samples that are generated from a good RCT are called experimental samples. If the sample is generated from the RCT, but the groups are dissimilar or there are baseline differences between those groups, then we call them as non-experimental. So RCT is the gold standard, should give me the experimental samples, which is acceptable, which is understandable. But if the RCT doesn't do its work well, the randomization doesn't work well, and the groups are dissimilar, I will not call that an experimental design anymore. I will say the samples are now non-experimental and they're analyzed differently as compared to a conventional RCT. This is accepted globally in every single field and every single journal. RCT की तरह behave करे, RCT से अच्छा sample create हो, तो analysis उसका RCT की तरह किया जाता है. अगर RCT से non-equivalent groups मिलते हैं, तो उसके analysis में और कुछ additional तब्दीलियां करनी पड़ती हैं. You don't treat it like an experimental sample anymore. RCTs are very well understood by everybody who is an IAPSM member. We have a population. We do some form of randomization, either at the individual or at a cluster level, to create two groups. One group gets the intervention, call it the treatment group. This other group we call the control group. One of those groups gets that program. We have baseline and endline in that group, and we have baseline and endline in the control group as well. At the baseline stage, group 1 is equal to group 2 because there is random assignment, because there is randomization. And if group 1 is not equal to group 2 at the end line, we say that the differences are because of the program. If that assignment is not random, if there is no random groups, if both the groups are dissimilar, are different at baseline, and they continue to stay dissimilar line, you don't know whether that dissimilar is the baseline dissimilarity or because of differences at baseline or because it is of the program. Therefore, random assignment or RCT always considered essential if you want to do impact evaluation. So one of the ways in which you can do impact evaluation is create an RCT. Make the medical college force them to identify 50, 80 different villages. Randomize them into groups. And from these randomized sets, a certain set of villages get the extra counseling for the health workers on conception. That would be the way to ideally test whether or not the extra counseling given by the medical college is making a difference. That's the simplest and the easiest way to do the answer. However, experimental designs are terribly difficult to conduct in programs because there are questions which come around spillover effects, because there are other programs, behaviors can get modified because of experiments, there could be selective participation and attrition, programs, if you deal people, some in the control group, maybe you're not dealing with it ethically. So therefore, all these questions make RCs very program situations. However, it is not impossible to do an RCT. Let me be frank with you, count as well. Several programs globally and even in India have used RCT designs, but basically they are essentially needed to be less complex theories of change. Programs which are simpler and smaller scale are more able to RCTs versus programs which are countrywide and very, very complex. One of the best examples of RCT done at a national level, which is the forerunner of all the conditional cash transfer programs done globally, is the Progressa, the Prospera, and also now known as the Oportunidades, which means opportunities, which is a conditional cash transfer program which was run in Mexico about 2 decades ago. And this is a parent program to the cash transfer programs have been started globally. So they do certain health conducive behavior and they get some amount of money which comes into their accounts, or they're paid some extra money to keep on motivating them or spending that money for several reasons. So experimental designs are doable, but are very difficult and they need planning from the beginning, because before you actually even run your intervention, your randomization has to be done. तो इवैल्यूएशन 5 साल बाद होना है, पर उसकी प्लानिंग अगर आज करोगे प्रोग्राम लॉन्च के टाइम, तभी आप उसको रैंडमाइज्ड ट्रायल डिजाइन से इवैल्यूएट कर पाओगे. Practically, very few programs undergo RCT testing. Okay, practically, not just in India, but globally. So what you are left with in the absence of good experiments are observational designs. You need a conceptual framework, you need appropriate data, you need a comparison group, you need a statistical model, and you also need an appropriate estimation strategy. So we all know what a conceptual framework is. So I'm using a conceptual framework where there is selectivity issues operating, where the program presence is driven by community characteristics. So the first and foremost, you need to have some kind of a sense about where the data for this impact evaluation is going to come from. Maybe for the individual level information, you will need household surveys, or data should come from there. For community, it can come from community or from facility surveys. You will then have to have a model which links up all this data together to say how the outcomes are justified. So maybe you have a funded program, there are other donors running that program, all of it works at the government level, it changes utilization of services, maybe individual characteristics are influencing service utilization and practices, and then you reach to an outcome. So create your own model for the situation, and then you have to get the complexities of the data into each of these, whether you're getting it from the NFHS, from the NSSO, whether you have a special facility survey like the DLHS, and whether you have data from all the programs, from all the national programs, as well as the local, regional, or funded programs. So it's a very, very complex situation. And the difficulty is all the data that is collected will be different data sets, different time periods, different coding, and you have to get all of this into your impact evaluation data set so that you're able to do an impact evaluation. Very complex task. Trust me, this requires very high-end statistical skills. We have individual level factors. We have household level factors. We have community level factors. So you need to have hierarchical models which explain that if the intervention is happening at the individual level, and if you have some other data points which are at the household and community level, how do you integrate all of those into your estimation model and into your strategy. It requires a lot more complex models than what we routinely encounter. I will give you a taste of what is the kind of estimation strategies and what is the process of thinking behind it in the subsequent set of slides. So with all this data, you should be able to identify other community characteristics, health service supply, some factors which are community or clinic based, and so on. You get good data, but that doesn't mean you can do. Data मिला है, counterfactual कैसे बनाओगे? Now these are 3 classifications that I'm showing you, which are made by me. So, okay, so these are not standard classifications, but this is something that will help you understand better. Each of these names might sound new to you. We have like simple linear regression, which is a single line equation. We can have a single equation program impact model in those conceptual frameworks where there is no self-selection problems, which means if I have a design like with a conceptual framework of this kind, the basic model of the conceptual framework, where your program is not in any way external to any of those boxes, I will use a single equation model. If my model or conceptual framework becomes like this, where program participation is driven by some other set of characteristics, or it is driven by community level characteristics, in such situations, I will have the second, which is written in red, self-selection or targeted program placement, which requires not a single line equation, but a multi-line equation model, which could be of different subtypes, using a design or a method called instrumental variable approach, pure econometric technique. It is, if you ask me for what is the analogy that I can give you, it is like the screw of Archimedes. Archimedes is once famously, it is attributed to him that he said that if you give me a screw which is large enough, I can move the whole world for you. Instrumental variables is a very, very, very powerful concept, but deceptively simple to look at, but very tricky to implement. Because instrumental variables introduces a new third variable, also called as an umpire variable sometimes, into your equation in order to identify program impact. When we teach instrumental variables as part of an international workshop that I referred to earlier, this is the most difficult session, which continues into nearly 1.5 days of teaching, which includes a huge whiteboard. 2 such whiteboards are placed side to side for the equations to be drawn, for the proof of concept to be explained. One of the most difficult sessions to understand, but the concept is a beautiful concept. And after RCT, if you ask me what is the best method to give me program impact evaluation, it will be the instrumental variables method. The next set of methods, because instrumental variables are very difficult to actually get and do the analysis with them, the most commonly used impact evaluation observational methods in self-selection issues with self-selection are the longitudinal data models, called as the first difference, the difference in difference models. So we calculate first differences, second differences, and something called as a difference in difference approach. And with this technique, we are able to get more insights into the program impact in comparison to a very simple model as such. Again, this design with its statistical programming in Stata, working on the data sets, this is roughly about 2 days of complete full 2 days given to a team which understands high-level statistics. We can explain the concept of longitudinal data models. Another popular approach which is used, usually in conjunction with longitudinal data models, is matching. So there are different types of matching. So we can have simple matching, or we can have propensity score matching. A simple matching, which is either based upon a distance measure like the Mahalanobis distance or a simple Euclidean distance, versus a propensity score matching where you calculate a lot of eigenvectors to give you what are those sets of factors, and you calculate a new variable called as a propensity score and then do matching based on those, and combine that matching approach with a difference in difference method is something which is considered as fairly acceptable and rigorous enough to give me a valid estimate of the impact. Further down in importance come in other clever approaches. This one is one of my personal favorites, called as a regression discontinuity analysis. Conceptually very, very interesting, simple and easy, but can work only in certain limited conditions where instead the outcome variable is a score variable with something called as a very clearly defined threshold to determine program criteria and so on. So for those of you who are interested, I will also be giving you access to free literature which explains in detail all of these methods with their statistics and with their analytical approaches. So I will definitely give you access to that resource as well, which is completely free of cost. And you can work on it individually and try to get to your answers. The point that I want to make on this slide, impact evaluation uses different kinds of designs. Experimental designs, the RCTs, can be done, but are difficult to do. Observational designs are frequently done, but the observational designs to get to the counterfactual have names which are very different and methodologies which are very different, which are not covered as part of normal medical college teaching, not at the MBBS level, not even at the MD level. You can have econometric models, which are single line or multi-line. Single line are like the simple linear regressions that you run. Multi-line will be the ones where self-selection is at play. At the unity level, you have the longitudinal data models or the instrumental variables, or you have matching procedures or other clever approaches, several of which are available, out of which one is regression discontinuity. Now, what I'm going to do for you is show you a few slides. Now, just ignore this one slide at the moment. Let me come to the conceptual framework and how the conceptual framework gets linked to the analysis. Now I'm jumping into the part 3 of my presentation. Now, what the conceptual framework's importance is that it just doesn't tell you what data to collect. It also guides your complete analysis. It tells you which factor is to be considered how into your model. Let me explain that to you. Okay, so I'm seeing some chat going on that maybe my video or my voice is not available to some participants, while the organizers are saying that it is visible to them. Maybe it is bandwidth issues at the participant end. So please check whether there is any problem or whether there's any difficulty. So now I'm going to talk about how the same simple conceptual framework can be linked to analysis. Now I'm going to talk to you and introduce to you gradually to a little more of the complexities of statistics here. I will make it very simple. Please don't be alarmed by the terms that I'm going to use. I'll explain every single thing to you. If you have taken mathematics up to class 10, you should be able to understand what I'm going to talk about. Okay, so I'll build it up very, very simply and gradually. We have several variables in my simple conceptual model. Okay, I've taken up the outcomes, the intermediate outcomes. I'm just saying individual and community characteristics से arrow जाता है towards use of family planning methods. बीच वाला मैंने अभी के लिए गायब कर दिया है. What does this conceptual framework mean? It means age or changes in age influence use of family planning. Education and changes in education influence use of family planning. Socioeconomic status and changes in SES will change family planning. Each of these variables that are listed here, individual as well as community level, are impacting my final outcome. that is use of family planning methods. I start with the same problem. Some are observed, some are not observed. I give them color coding. So for this particular background, because I'm using green color, I've changed the background of my slide to white. Observed ones are in black, unobserved ones are in green color. So whenever you see something written down in green, remember it is unobserved. Anything in black, observed. Okay. So on okay, so till now all of you are able to hear me. Perfect, excellent, thank you. So now let us go to the next slide. Now what I'm saying to you and what I said a little earlier on the previous slide, that age is related to, in some way, influences use, education influences use. If I want to express it mathematically, how do I write it? Convention says that use of family planning, I'm shortening it the name to use, is a function of age, education, SES, rurality, programs, so the observed factors jo hain, as well as all the other unobserved factors as well, Vishavi. So this is very simple. I'm just saying that I am, whatever I've drawn, I'm expressing it in the form of an equation. I'm adding something a little bit more here. So what works at the individual level is I, and what works at the community level or is a community level variable, I add a J to it as a suffix. So I have age, which is important at individual as well as at community level, education, socioeconomic status. But look at rurality and programs. These are only community level characteristics. And of course, to complete my entire picture, I now segregate all my unobserveds and club them towards the end and say there is also risk aversion, there is also genetics, there is also health facility, there is also sanitation, which affects all the outcome variables. So it means use is a function of all these different variables. These are the variables that influence use. I've expressed that in mathematical language. Some are observed, some are unobserved. Don't forget that. We still have the unobserved with us. We don't have data on them, but because they were there in my conceptual model, they are still there in my equation. उनको गायब नहीं किया है मैंने, उनको अभी भी संभाल के रखा हुआ है, just एक जगह पे group कर दिया है. Now the next question that comes to me is, अब ये function जो है, जो मैंने कहा use is a function of all these variables, ये function का form क्या है? What is the functional form of this function? Is it a simple relationship? Is it a very complex relationship with a mathematical function which is of a different type? Is it following a certain distribution? Unfortunately, I don't know how all these factors and what that function is on use. I have to make some assumptions. I don't know that answer. The functional form is not yet known. I know there is a function, but I don't know what is the functional form. So what do we do in such situations where the functional form is absolutely unknown to us? Now, can I have some form of a functional form that is assigned here that will stand true in most and every situation? That's the question that we are asking ourselves. Does anybody have an answer as to what do we do here in these situations? Solution to this problem is not a recent solution. It's a very ancient solution to this problem. Very, very ancient. Okay, so let me get to the solution from my side. Now this is where the difficulty of our education system actually comes in. With the way we are taught our mathematics and statistics, we are taught ideas and concepts, and then we learn their application straight away without understanding why that concept is needed in the first place. जरूरत को हमने concept को हमें बहुत कम अपने स्कूल में पढ़ाया जाता है. Now I'm expressing the same thing in a slightly different language so that all of you can follow me. So I say, let us then go back to mathematics and statistics. What we have in statistical terms is outcome y is a function of different types of variables. Let's call them x1, x2, x3, x4, x5, and it can extend up to whatever number you want, but its function is unknown. The f is unknown. So y is a function of x1, x2, where f is unknown. Very similar, use is a function of age, use, SES, rurality program, risk, gen, HX, sanitation, but function unknown. So we're expressing it, y is equal to function of x1, x2. अभी के लिए x1, x2 रखते हैं, वो कहीं तक भी आगे extend हो सकता है. Now this looks terribly complex to look at, but I will explain to you like how I explain to somebody who's just doing 10th standard mathematics. This is famously referred to as a Taylor series expansion. It's a very simple polynomial expansion given in 1715 by Taylor. And we will just talk about this expansion at this stage. Now, what it means. Now, let me just try to see on screen if I can do a little bit of annotation on this particular slide, okay? So I'm trying to experiment out with something in annotation. So I'm taking a new pencil tool and just try to follow what I am highlighting here on the screen for all of you. Okay. Seems to be a bit of a difficulty today in the annotation. Give me a second, please. Okay, so are you seeing on the screen something that I've drawn in red? Is it visible to you? Can you confirm on chat box, please? Okay, thank you, Amit. Thank you, Aarti. Okay, so I will be using a simple annotation tool to explain some things for you. See, you have two variables at the top, two x variables, x1 and x2. Very simple, okay? Two variables, x1 and x2. So what I do first is I say y, instead of the equal sign which was present here, here I'm bringing out the approximation sign. So I say y is approximately equal to, and just look at the first three terms here. What I've done here. The Taylor series says it is alpha 0 plus alpha 1 x1 plus alpha 2 x2. Just pay attention to the first three terms which are drawn up there. Okay. So I'm raising up what I've drawn in red. Now what I'm showing to you is the most simple aspect of everything that is drawn up here. I'm saying alpha 1 x1, alpha 2 x2, and alpha 0. Alpha 0 is nothing but your intercept. So I finish my first three terms, and then I take alpha 3 as a new coefficient. यहाँ alpha 1 alpha 2 हो गया था, alpha 3 लिया, और मैंने फिर कर दिया x1 and x2 को combine कर दिया. So I'm taking an intersection of x1 and x2 together. So the first part that I have done in my Taylor series expansion is the simplest aspect of nothing but, sorry, so it seems that you escaped from the screen. So the screen is again visible to all of you. We have the Taylor series expansion where we started with the first simplest aspect of this part of the Taylor series. There's an alpha 0, there is an alpha 1 x1, alpha 2 x2, alpha 3 x1 multiplied by x2. This becomes my first part. Look at my second part. Second part mein I will take x1 square, x2 square, and x1 x2 square product and add coefficients in front of it. Then I take x1 cube, x2 cube, x1 cube, x2 cube. Then I take x1 to the power 4, x2 to the power 4, x1, x2 both to the power 4 as a product. Just see the highlighted terms in the sequence in which I've given to you as separate terms, which are all getting added together. The concept is first add to the power of 1 and take the product to the power of 1. Then add the squares and the product of the squares. Then the cubes for x1, x2, and then the product of the cubes. Then take the power to the 4, x1, x2, and the product of x1, x4. And this keeps on continuing till order n. So just is an approximation. Even if I do not know what the function is, I can very easily, Taylor tells me that for an unknown function, all that you need to do is take to the power 1, add the coefficients, take the product, add to the coefficients, then take the second power, then do the same thing and keep on continuing. This Taylor series approximation is further approximated to the linear part of it, where we just take the first 3 terms. So the first 3 terms are alpha 0, alpha 1 x1, alpha 2 x2. We take those, and this is how we express y is nothing but alpha 0, alpha 1 x1, alpha 2 x2. Very much like your equation of a straight line. Okay, so this is basic mathematics of 1715 given to us by Taylor that we will make use of. Let me go back a couple of slides. I do not know what is the functional form of this relationship of u's with any of the variables. I use a Taylor series expansion wherein I take to the power 1, to the power 2, to the power 3, to the power 4, and put those terms and their interactions and add those all up together. And we use only the very, very, very basic form, the linear form of it. So interactions ये जो है ना, इसको हमने गायब कर दिया. ये जो non-linear exponential है, इसको भी हमने गायब कर दिया, गायब कर दिया, गायब कर दिया, गायब कर दिया. हम केवल इतने को लेके ही आगे चलते हैं. However, if you so want, you can add interactions sometimes, and sometimes we even use the higher powers. So to the square wale power bhi hum impact evaluation mein use karte hain. But this is just a way of giving to you the concept of how the statistics, the basic mathematics progresses to tell us how the equations are actually going to work for us. So using this understanding that Taylor provided us, we now say that use ij, which was a function of all the variables, is now we are going to rewrite it. And this rewritten form of the linear form of the expression is going to be alpha 0 plus alpha 1 age, alpha 2 edu, alpha 3 SES, alpha 4 rural, alpha 5 program variable, plus alpha 6, alpha 7, alpha 8, alpha 9 for the unknown variables as well. Remember, unknown variables abhi bhi maujood hain yahan. Is this concept getting clear to all of you as to now from an unknown function, I now have a statistical form which I can put into a software and analyze. Alpha लिखो या बीटा लिखो या गामा लिखो या डेल्टा लिखो, वो आपकी पसंद है. Usually on the biomedical side, we write our coefficients as beta 0, beta 1, beta 2, beta 3. Economists sometimes prefer to write alpha 0, alpha 1, alpha 2. Doesn't make a difference. जो भी नाम उसको देना है, आप दे सकते हैं. Is this concept how we transition from an unknown function to an acceptable approximate functional form, which is a linear form of a relationship, is what is created here. Let me go back a few slides. Let me remind you, we started with a very simple conceptual model with no self-selection issues. And remember what we said in some slides a little while ago. We said there will be a single line equation model which will explain a simple relationship. So I'm going to create a single line equation model for you which explains this relationship, where observed and unobserved are still retained. The unknown functional form using Taylor series expansion is expanded to give us an equation, which is all available with us. Now I'm going to do something with this equation form. Look at the basic structure. It has two parts to the equation on the right hand side. It has a black and a green part. My black is the observed variables and my greens are the unobserved factors. So I now summarize all these unobserved. मुझे पता है वो मौजूद है, और unknowns को मैं summarize कर देता हूं into a very standard term called epsilon. This is the Greek letter epsilon, which is sometimes referred to as the error term. Error, E-R-R-O-R, because that is going to bring the error into all your conclusions. So it's called the epsilon or the error term. So the same equation use ij that you see on the top of the slide and at the bottom of the slide is the same, except that the greens are now all subsumed and added and collated and collected in the epsilon term. And the epsilon term has something which has come from I and something which has come from j. So the epsilon also has two parts, some coming from the I, some coming from the j. So it's an epsilon ij. So my equation, the single line equation that I'm getting to, is that use of contraception as per my conceptual model is now summarized to a shorter form wherein I say it is alpha 0, alpha 1 age, alpha 2 education, alpha 3 socioeconomic status, alpha 4 rurality, alpha 5 program variable, and all the others, that is my epsilon. Remember, epsilon को भूल मत जाना, क्योंकि epsilon दूसरे determinants को भी linked है, और एप्सिलॉन आपके लिए बहुत आगे दुविधाएं कर सकता है, इसलिए उसको भूलिएगा नहीं. एप्सिलॉन को भी अपने दिमाग में रखिएगा जब आप एनालिसिस कर रहे हैं, because they are related to the other determinants as well. Now these unobserved variables that we put in our epsilon were your alpha 6, your alpha 7, your alpha 8 and your alpha 9. Some of these are individual level, conceptual model में individual level से आए थे, and some came from the community level unobservables. Okay, so now we'll play a very simple game with all of you. I'm putting the large equation that I had where my epsilon is expanded and I'm seeing all of them written down. You also have the model in front of you, and I'm going to just ask you very simple questions. Unmute yourself and tell me what will happen. Look at the picture and look at the equation. Picture देख के समझना ज़्यादा easy है. If I improve the education in my village, what will happen to family planning methods?
There'll be more uptake of family planning methods.
Exactly. That is Suchitra Mankarji, that is right. There is a change in use that will happen. We hope that is going to be positive. That's what you and I believe. But what this picture says is there will be a change in the use if education changes. What will happen if now an unobserved factor, health facilities, increase within that area? What will happen to use? Will it stay the same? Will it change? Okay, so I'm seeing a couple of answers coming to me privately on the chat. Yes, there is an improvement, there is a change. Sure, that's great. So again, we see a change in use. So irrespective, okay, in this simple conceptual framework, irrespective of whether you take a factor at the individual level or at the community level. अब देखो program लिया है, program भी community level है, observed factor है. What will happen to use? Of course, there'll be a change in use. So there is going to be a direct and a unique relationship between each determinant that you're seeing in your conceptual framework with use. Direct and unique relationship. एक को change किया, use change होगा. दूसरे को change किया, use change होगा. Direct relationship है. कोई बीच में complexity नहीं है. Unique है. Age के साथ उसका specific कितना change होगा, वो मुझे alpha 1 बताएगा. Education से कितना use change हो रहा है, alpha 2 बताएगा. SES से कितना चेंज हो रहा है, अल्फा 3 बताएगा, प्रोग्राम से कितना चेंज हो रहा है, अल्फा 5 बताएगा। और जब मुझे पता चलेगा डायरेक्ट एंड यूनिक रिलेशनशिप है, तो प्रोग्राम की वजह से कितना इंपैक्ट हुआ है, तो अगर मैं केवल अल्फा 5 को देखता हूं, if I only focus myself and look at alpha 5, this particular coefficient, this is the impact of my program. And I can say this is the impact of my program because my entire conceptual model that I've drawn up here is explained by a single line equation model. This is the simplest form of analysis. This is a single line equation, very similar, and actually it's the same as ordinary least square regression. This is called an OLS model. And this OLS model gives me the program impact if this is the conceptual framework that I'm going to start with without any problems. I can get an answer because there is a direct and unique relationship. What is IJ? IJ is nothing but individual level characteristic or community level characteristic. We defined it at the very beginning when we started our discussion here. So let me take you back to that slide where we defined what is I and J. So we said, let me go back here. We started with this conceptual framework, and then we added the I and the J here. So remember, this slide doesn't have the IJ. Here I have the I and the J that is added to it. I represents individual level characteristics and J represents community level characteristics. Okay. So we played this simple game where education, health facility, program, everything caused a direct and unique relationship with use, and therefore we saw a change. Now let me just change the conceptual model. Here, the medical college placed the program in a certain village because that village had a high burden of unwanted pregnancy. So eligible couples, we thought, there is more need for counseling, and therefore the medical college decided to place the program there. It was not based on the randomization. And whenever it is not based on the randomization, this is the situation of self-selection that we have entered into. Self-selection placed by the program. Program has self-selected the community to get the program. So now it's the same characteristics: age, education, SES, risk aversion, biology, rurality, health facilities, sanitation. But my program no longer here in the community characteristics. Something in the community made me choose to offer the program there. So now the situation is a little different. Here again, I will do the same things. Something is unknown, something is known. So you have your blacks and the greens. And I write the same equation. Now this equation, look at and read the equation carefully. It says use is influenced by alpha 0, alpha 1 age, alpha 2 education. Let me start annotating as well. So I'm taking age, I'm taking education, number 3 is my SES, number 4 is my risk aversion, जो भी होगा, risk aversion alpha 6 है इधर, then biological endowments or genetics is alpha 7, then I have rurality which is alpha 4, I have health facility which is alpha 8, and I have sanitation which is alpha 9. So what this equation use IJ is capturing, it is capturing this arrow and it is capturing this arrow. So this part of the relationship, which is absolutely similar to my previous picture, is captured in the first line of my equation or the statistical model. But now there is another arrow which is actually coming towards my use. This is an extra thing which was not there in my earlier model, which is this particular arrow. I need to have an equation for this arrow as well. So what I say, program, or for that matter, let me, before this particular arrow, let me start talking about this particular arrow here. So I'm talking about what is influencing my program. So my program is getting influenced. Is it getting influenced by age? No, my program placement is not influenced by age. There is no arrow that comes in here. Okay, so my program is influenced only by community characteristics, which is denoted by an arrow which comes here. So I say program is influenced by rurality, health facility, sanitation. So rurality, health facility, sanitation. I've called them beta. So beta 0, beta 1 rural, beta 2 health facility, beta 3 sanitation, and all of this influences program. So what I've shown you here is that this conceptual framework is different because there is an incoming arrow not just to family planning, but there's an incoming arrow also influencing the program. I need to have a second line equation as well to depict this conceptual framework, which is what I've shown as part of the mathematics. Now this model has two equations, and please note equation 1 is the same or it's identical to what was there on the previous slides. Equation 2 is now your addition. Okay, so now let us play the same game that we played a little earlier. What will happen if I improve education in the village? What will happen to use? So can I have somebody answer that question for me? What will happen to use if I improve education? Come on, any suggestions? Somebody to unmute.
Increase in the use.
Okay, so there is a change. Okay, I agree with you very much that you see change in use. Now look at the variable that I'm changing. I'm changing another individual variable, which is an unknown variable, which is risk. Even there, I will see a change in use. Do you agree with me? Is it correct or is it incorrect? Okay, so I'm seeing privately somebody's telling me, yes, there is a change, it's correct. Now be careful. Now I'm changing health facility in the community characteristics. What will happen to the use? Will it change or will it not change? Anybody wanting to volunteer with an answer here? Yes, Devashish, that's correct. Yes, there will be a change in use. So now if I change health facility, there is certainly going to be a change in the use. But this change in the use operates through two pathways. It operates through a direct change in the use as part of this arrow, or it changes because the health facility changes program, and then through the program route, it changes the outcome variable. So there are two ways now in which presence of health facility is changing contraception use. Unlike the earlier example, here health facility will change it by directly changing family planning methods use and by operating through program and then through the program changing family planning. The moment you understand this, that there are different types of arrows, which means we don't anymore have a unique relationship between health facility. So the community characteristics, if you look at these arrows that come out of the community characteristic, they're influencing program, and all these three, rurality, health facility, and sanitation, don't have a unique and a direct relationship with the outputs. मैथमेटिक्स में सब कुछ सॉल्व किया जा सकता है जब आपके पास डेटा हो. अगर मेरे पास डेटा है तो मैं सब कुछ रूरलिटी को सॉल्व कर सकता हूं, क्योंकि मुझे पता है कुछ पार्ट इंप्रूव कर रहा है फैमिली प्लानिंग को और कुछ पार्ट कर रहा है प्रोग्राम फैमिली प्लानिंग को, मैं कर पाऊंगा. बट अगर दो तरीके से यूज चेंज हो रहा है और उसके लिए डेटा भी नहीं है मेरे पास और वो अननोन वेरिएबल है, and then I can solve that equation. That it will go, and then the way I can say how much of the change in the use is because of direct effect of health facility on use and indirect effect of health facility through program on use. Are you getting my point? So my problem in my data set will start arising the moment I have a two-line equation with some variables which do not have presence in the data set, unknown variables जिनका data available ही नहीं है मेरे पास. Now evaluation answer, when I say what is my true program impact, my true program impact is actually just this arrow. Program की वजह से family planning कितना change हुआ. Nothing else is what I'm interested in. If I am Arjun, my target is the eye of the bird, and the eye of the bird is just this arrow. I am not interested in anything else in this equation. My core interest is what is the change in the outcome? What is the change in family planning, which is because of my program? Now look at something like health facility. Health facility is creating problems for me because it is causing a change in my outcome through paths, through the pathway of the program, and also independently directly on the family planning level. And उसका data भी available नहीं है मेरे पास. Unknown variable जिसका data नहीं है मेरे पास, जो मुझे पता है influence कर सकता है, data collect करने का कोई तरीका नहीं है, I will never be able to solve this equation. This two-line equation will become unsolvable. Therefore, I will need to have an estimation strategy which will have to now correct for all these problems, because a simple equation which is of two lines where there are unknown variables affecting the outcome variable will completely decimate my impact evaluation calculations. Impact evaluation करने का मुश्किल जो काम है वो इसीलिए है क्योंकि conceptual model में बहुत सारे unknown variables हैं जो हमें जानते हैं, जिनके बारे में हम कि ये important है, पर जिनका data नहीं है. अगर data मिल जाए फिर भी बहुत सारे variable मिल जाएंगे जिनके बारे में हमारे पास information नहीं है. अगर information मिल गई तो टू लाइन इक्वेशन मॉडल भी सॉल्व हो जाएगा, पर इंफॉर्मेशन गायब है तो टू लाइन इक्वेशन मॉडल आपको खत्म कर देगा. ओके, सो दिस इज व्हाई impact evaluation very often gets stuck and we cannot do a good impact evaluation because our conceptual models are always like this, जिसमें program placement is decided by program manager. Program manager says कहाँ क्लिनिक खोलना है, कौन सा इंटरवेंशन देना है, किसे इंटरवेंशन देना है, कब इंटरवेंशन देना है, कितने समय तक इंटरवेंशन देना है, is all decided by program manager. So you're always or near always in a two-line equation situation. And whichever survey you take, NFHS, NSSO, your own medical college survey you take, a lot of this information will be missing, which is there in a broader conceptual framework that affects the choice of family planning methods. Women empowerment, for example, is such an important thing in family planning method adoption and use. In fact, in some rural areas of India and sometimes even in some urban communities, you see, rather than it being just the wife who decides along with the husband as to what family planning method should be used, sometimes it's the mother-in-law who also decides what family planning will the couple use. So if all those things are added to your conceptual model, do you have individual level data in your data set? It will not be there. There will be these unknowns. And the moment you have unknowns like these, your impact evaluation goes wrong. And if it is there in your conceptual model, it should be there in your equation. If it's there in your equation, it becomes part of epsilon, which needs to be answered. So what I'm getting to is, if I want to calculate my program impact, I cannot use a cohort or a case control design. I will have to have designs such as, or methods such as instrumental variables or longitudinal data methods, or the other clever methods like regression, discontinuity, so that we are able to identify and remove the effect of these unknown variables. अननोन वेरिएबल्स जब आपके इक्वेशन में आते हैं, केवल दो तरीके हैं उसको प्रोटेक्ट करने के. एक, अननोन को ऑब्जर्व्ड फैक्टर बना दो, उसका डेटा कलेक्ट करो, या फिर आरसीटी करो जिसमें बिकॉज ऑफ रैंडमाइजेशन द अननोन वेरिएबल्स आर बैलेंस्ड बिटवीन द टू ग्रुप्स. No other design other than the RCT balances these unknown confounders or variables between these two different groups. And every single time, therefore, you will have to do impact evaluation, some completely different sets of designs, such as the IV, the longitudinal data models, and the other techniques, so that you're able to correctly identify the program impact. So whenever I sit as a reviewer for articles which come on international journals in impact evaluation, we never look at the answer, we never look at the program, we never look at the impact answer. First and foremost, we look at the methods. We try to look at what techniques they have used to convince us that the impact estimate is an unbiased, valid, and correct estimate. If the method is able to convince me that the counterfactual status without program situation, the counterfactual status is created adequately, and then the statistics is taking with program and without program in observational designs, and then telling me what the impact of the program is, I will then be more likely to trust and accept the. Otherwise, we reject all of it. Impact evaluation is an expertise area. This 3-hour session for all of you is not going to make you doers of impact evaluation. At the very least, it can sensitize you and tell you that what is and what isn't impact evaluation. Number one, the session tells you that in order to do an impact evaluation, the methods and the techniques are all designed in order to get a good counterfactual. Number three, if you want to do an impact evaluation, you'll have to get in experts who understand how to do an impact evaluation using high-level econometric techniques. So I will just like to end with this one slide. This is a cartoon or a joke which I always like to share at the end of this presentation. You have a person like an impact evaluator who's standing in front of a crystal ball, who is the vision of sorts. In front of him comes in a policy maker or somebody who runs the program. He says, tell me whether my program works. And the impact evaluator is asking a question back in return. How do you want the answer? Do you want me to give you a crystal mumbo jumbo, or do you want me to give a statistical probability? It's obvious you have to give a statistical probability. But in order to give a statistical probability and not just a tukka, मुझे लगता है कि ये प्रोग्राम अच्छा काम करता है, is a very, very faulty crystal mumbo jumbo. Rather, prove it and say that yes, the program actually makes this much of difference. In order to get to it, is asking a question of expertise domain area called as impact evaluation. So with this, I come to an end of what I had planned to cover in the session with all of you. Now I'm open to questions. We have about 5 to 7 minutes for any queries or questions from people in the group.
I have a question for you, if I may, please.
Dr. Suchitra.
Hello. Yeah. So I'm, well, thank you for a very, very comprehensive and exhaustive presentation. Took all my mathematical genius to stay with you. But my question is that lot of interest in health impact assessment because of the recent change in the CSR Act and companies maybe like ours now in the rat race to sort of get these on our board. And that is why I wanted to listen to you and as an expert in the field. My problem is that the rule has just come and it's for projects which have been for the past 3 years. Clearly, many CSR projects have been done not with the health impact at the end of it sort of idea in mind. So we are going to land up in a place where, well, we have to say, okay, it's great, go ahead, and now onward start keeping this kind of a data is how I see it going to happen. Any suggestions, comments on this from your side? Because I don't think this mathematical model is going to work there because nothing would have been identified in the beginning, for example.
It's a very relevant question, and it's very close to the reality and the situation that exists at the field level. Let me answer it a little bit in a roundabout and a longish way again. What is easy to do is to count the number of beneficiaries or give a head count and say, my project impacted the lives of 30,000 women and children in a particular district of a country by running this CSR project. It gives you the headline numbers. It is just counting the beneficiaries that have visited, but makes it sound as if there's a lot more done than to what actually happened. When we say we are interested in what difference did you make? Now, if I ask a question in a slightly different English, did your program make a difference to their lives? So you could have distributed sewing machines to all the women in order to start earning more income. But did their income actually change? If you ask yourselves that question, that's a question of impact evaluation. I'm not saying that all projects should get an impact evaluation. That's not what I ever want to happen. But if you have a sizable investment that you're putting in, and if you want to reconsider the amount of money that you are spending for a certain project A versus a project B, the obvious question will be, is it a prudent choice to shift my resources from activity A to activity B? When I come to that question, you will have to hire an external evaluator who will come and then create an evaluation report for you and tell you whether or not your program works. Now, very often that external evaluator, because he or she doesn't have access to all the data because it's not collected, does a process evaluation. And the process evaluation says how much of outputs you have got and whether the outputs were on intended or expected lines. But it doesn't talk about long-term outcomes. So this is a distinction that you will have to draw whenever there's any CSR activity that you are running. Number one, are you willing to introspect and say that you want an evaluation to tell you whether or not it worked or not? Number two, or are you satisfied with the headline numbers of process that you're getting? We touch the lives of so many people. So there's a difference between touching lives and impacting lives. It's not just a play of words. So I'll probably rest my case there. So it has to be preferably, if it is impact evaluated, make a decision early, bring in a consultant just to sit with you for 10 to 15 days and work out a plan for impact evaluation over time so that you're able to get a very, very detailed structure ready so that 2 or 3 years down the line, you will be able to conduct an impact evaluation in detail with an evaluator. That's all.
Thank you so much. Thank you.
Yes. Do you have any more questions? I guess there are many questions we address in between the session. Yes, Dr. Aparna.
Sir, thank you for the session. I just wanted to know that if we want to read more on this topic, where can we go and read about the topic? Because it's very difficult to find anything.
I will give access to the resource, a free, complete textbook with everything associated with what I have talked is taken from the same text. I will give you a legitimate copy that you can download and keep with yourself as a resource material. It's a textbook on impact evaluation written by somebody who's a collaborator with whom I've worked extensively on impact evaluation from the University of North Carolina. So I will definitely share that resource, but please wait for a day. I will send it across late evening to the organizers, who can then mail it to all of you tomorrow based upon the criteria, whether you've participated or not, and whatever is decided by them. Okay.
Thank you so much.
Any more questions from the participants?
See,
Okay,
let me confess, I am decently good at statistics. I'm a very good epidemiologist, but I'm decently good at statistics. So all that I've explained to you is complex भाषा को थोड़ा सा simple करके जो मुझे समझ में आता है, वो मैंने आपको समझाया है. तो I run a lot of analysis in Stata. I'm comfortable using the nomenclature that Stata uses for a lot of the analysis. So we do not just run the logit models, but we also run the probit models, which are slightly different from the logit models. Each have their own advantages, how we actually run them in impact evaluation, what the structure should be, what the Stata code should be. All of that will be there in the resources that is provided to you. So feel free to explore it. More than the presentation, trust me, that book is going to be something which is a much more useful resource for you. I've given you the flavor of the dish, but how to cook the dish and eat it is going to be your decision. All I can state is, depending upon where you're coming from, whether you're a program person, then the lesson for you is plan your impact evaluation early. If you're on the CSR side or the funding side of things, please do not use the word impact evaluation loosely. Get in somebody early and spend 1 to 2 lakh rupees to get an idea in place as to what all will be required to be collected once you're planning a new project. That is an expertise domain area of impact evaluation. Get some consultancy earlier. Number 3, if you want to do the analysis, don't do it alone. Keep a very good statistician or impact evaluator with you at all times. So if you want me to summarize, these are the 3 things as part of the session.
Hello, sir. Excuse me. I want just to know whether means which type of method of the various methods which you explain we prefer, or which is the commonest or easiest to use.
None of these is easy. The commonest, which we see with about 70 or 80% of the literature, is a combination of propensity score matching with a longitudinal data model which is used. Then comes the RCTs, although RCTs are the gold standard, but they're not as frequently done.
Okay.
Yes, sir. Thank you. Okay, any more questions? I'd hope that participant can get back to the Himanshu sir on email also if they want to talk with him. I take a liberty to share your email with them if they have any question, and of course you are going to share the resource materials. So I thank you, Dr. Himanshu, for the wonderful session and explaining this topic in a so simple way. I understand that the health impact evaluation is not an easy task to do, and it is more difficult to explain in a simple way. And so you had done it very wonderfully within a 3-hour time. So I'm sure that the participant has now more confident about the health impact evaluation, and now they learn the way to do it in a better way. So thank you so for that, and thank you for sharing the resource material with the participant. This will definitely help them. One more request to the participant that I share a feedback form link with you. So please fill that form as soon as possible. We need this for our documentation purpose and for also the certification purpose, because this is a system generated. So who will fill the feedback form will get the certificate. And I guess that that's from the my sides, and sir has also concluded. Any more comment you add, sir? Here you want to add here, Dr. Himanshu?
No, Ahmed, thank you very much for the smooth arrangement for the entire session. I'm always perennially grateful to Dr. Garg sir for interacting with us on different fora, for having encouraged us to participate as at AMS over time. Thank you very much.
Yes, sir. Thank you, sir. Thank you for participation. I thanks all the participants for the patient listening and the comments, and also the co-host Dr. Ruchita for making this web-based platform easy for me and for the participant. Thank you all. So with the permission from the resource person and from all the participants, I conclude this session here. Thank you all.
Thank you very much, everybody. I'm seeing a lot more that is coming on chat to me privately as well. I can only say that I'm always willing to take additional sessions wherever required when the platform of IAPSM is available, conducted over the years. And we look forward to an opportunity to meeting some of you next time when we have a physical conference as well. So feel free to reach out, feel free to keep in touch. All the very best to everyone here in this workshop. Thank you.
Thank you, sir. Thank you all. I stay here for a few more seconds. The participant can use the.
Sir, regarding the recording session, will you share it, sir?
Yeah, I will. We will, if the organizing committee after concluding this conference and all these things, we will edit the video, and after taking the permission from the resource person, we will share the recordings. It's a mandate to take a permission from the resource person.
Yeah. Yes, sir. If
We
you
have,
share, it will be used for our future reference.
yeah,
also.
sure. We after this conference, we will send an official email to the this resource person, and if they allow us, then we will definitely share it.
Thank you, sir. Thank you.
Thank you. We have some overlapping session also, so we are going to share this thing with the that participant who had the overlapping session and who are not able to attend this. Okay then. If you have any query or question, I am here for 1 more minute. You can ask me, and then I am going to end this meeting. Please fill the feedback form. It is mandate for the certification.